Hello, and welcome to the Frontier Nursing University virtual event for National Midwifery Week. This is Dwayne Golden, faculty at Frontier Nursing University from the Midwifery and Women's Health track. And we're thrilled to welcome Dr. Lisa Chism to speak with us tonight. And I just wanted to give a little introduction about Dr. Chism's practice. Dr. Lisa Chism is a certified nurse practitioner, currently practicing at Karmanos Cancer Institute, Alexander J. Walt Comprehensive Breast Center, and the Women's Wellness Clinic. She's also the clinical director of that practice. She's been a nurse practitioner for 23 years. Dr. Chism is also a certified menopause practitioner through the North American Menopause Society and an ASSECT certified sexuality counselor. Dr. Chism was inducted as a fellow of the American Academy of Nurse Practitioners. She was also selected as Menopause Practitioner of the Year by the North American Menopause Society in 2011, and she currently serves on the board of directors at the North American Menopause Society. Her interests include spiritual care and nursing practice, development and promotion of the DNP degree, and caring for women with a history of breast cancer, including their menopause and sexual health-related concerns. She has published and spoken extensively in this area of women's health. Dr. Chism, we welcome you to our virtual event.
Dr. Golden and Dr. Houston for asking me to speak. I'd also like to thank Brittany, all of their assistance with this presentation. I'm excited to be here with you, and congratulations as you celebrate this week, National Midwifery Week. Just a little bit about my practice. I know Dr. Golden told you all that I am coming to you from Detroit, Michigan, and my practice is really within a NCI designated cancer center. I primarily care for breast patients, all things breast health and breast wellness, including patients with new breast problems, patients with a history of breast cancer. And within this practice, I started noticing that women were not being adequately cared for their menopausal needs, especially once we either induce menopause or take them off of their hormone therapy because of a breast cancer diagnosis. So I became interested in this work. I became certified as a menopause practitioner and practice. I realized I didn't really know enough about sexual health and how to care for women's sexual health needs. As you'll see through the presentation, there's quite an overlap once women go through menopause with sexual health concerns, specifically genital urinary syndrome of menopause and dyspareunia. So we'll be talking about that. The presentation is really set up as case studies. So hopefully that'll help and meet your learning needs and learning styles. So I developed this practice within the Women's Wellness Clinic. So while I'm caring for primarily breast patients, this has been a wonderful, rewarding part of my practice, and I'm really excited to present this information to you. So you already know who I am. I am the clinical director of the Women's Wellness Clinic, certified as a nurse practitioner, as a menopause practitioner, and AASECT certified sexuality counselor. And that's my email. I think the last slide of the presentation does have my contact information for you, and we'll go over that at that time. So I'm going to present to you the first case, who is a 53-year-old female patient named Janet, not an uncommon patient that I would see, whose final menstrual period was 3 years ago. By the way, menopause is defined as 12 months since the final menstrual period. Once you have gone 12 months, you are considered menopausal. You don't need to do blood work. You certainly should not do saliva testing. And there is really no need for any kind of other evaluation to confirm menopause. It's 12 months after the final menstrual period. This is also included when we induce menopause with things like chemotherapy or endocrine therapies for breast cancer treatment. But I just wanted to mention that because one of the things I constantly am counseling my patients about is once you've hit 12 months, you are menopausal. If you bleed after that, it should be worked up with at least ultrasound and some kind of endometrial sampling. So I just wanted to make sure I mentioned that. I know the lecture isn't about menopause, but there's so much overlap between sexual health and menopause. I want to make sure I mention that. So this patient is in a monogamous relationship and she's verbalizing decreased desire. She's managing her vasomotor symptoms or her menopausal symptoms with over-the-counter remedies. She's talking to you about decreased desire. And what do you do with this information? And where do you go from here? The literature has shown us that nurses feel that time constraints and their personal level of comfort talking about sexual health content were the number one barriers that were noted in addressing patients' sexual health concerns. We see this clinically and we see this in the literature. So how do we fix this? We have to get comfortable and we have to increase our knowledge base and resources for patients. So increase comfort. Now I know that many of you are watching this lecture from your homes. I'm hoping you were able to pair up with someone. I'm hoping that you're able to be in some sort of group setting. I'm going to give you a minute to at least look at someone, even if it's a family member, in the eye and turn to them. And they're looking for this. And every time I do this talk to a group, and it can be medical students, it can be nursing students, practicing nurse practitioners, practicing physicians, anytime I give this talk, it's many giggles. So I'm trying to give you a little bit of time. Now I'm at a disadvantage because I can't see you. And when I normally give this talk, I can see, and I literally tell them, I'm not going to go forward until I see you turn to someone next to you, which elicits more giggles. So hopefully by now, you'll do yourself a favor because this really does work. And you've turned to someone next to you. And I want you to repeat after me. Penis, vagina, stimulation, vibrator, masturbation, penetration, dilator, orgasm, arousal, intercourse. Now, this in person to a group, there's even more laughter now that they've finally been able to do it. But there's a reason for this exercise. And if you can't do it during this lecture, find some time to do it when you are in a group setting with your colleagues, with your friends and family. The reason why I always want folks to do this exercise is, believe it or not, the more comfortable you are saying these words to your patients, the more comfortable your patients are going to be. There's something magical that happens when we talk to our patients and we say these kinds of words and terms and talk about these topics as easily as we would be talking about their prenatal care, their prenatal vitamins, their diabetes, their hypertension. If we can speak to them as easily as we speak to them about these other issues and say these words rolling off our tongue like it's no big deal, within about 10 seconds, patients eventually will meet you eye to eye. They'll start talking to you. They'll know that you care. They'll know that you're comfortable. And even if you don't have all the answers or all of the information, they will at least open up to you to begin to talk about some of these sensitive subjects. So this really is an exercise that if you don't get to do now, that I really do encourage you to do at some point. And then I encourage you to do it with your patients, because the more comfortable you get, I guarantee you, it's magical how much they calm down, look you in the eye, they stop blushing. I've even seen partners in the room look away, get uncomfortable, and within about 5 minutes, I've got them paying attention and being able to look me in the eye as well. So we are talking about comfort. How do we increase our knowledge base? Well, I'm going to try to give you in about 35-40 minutes the most pertinent information that I can pull out of my years of experience and the 13-month sexual health program that I went through at University of Michigan to become AASEC certified. So what I'm giving you is the greatest and best pearls that I can come up with to try and increase your knowledge base. So I'm going to review the sexual health models. I'm going to review assessment of sexual health issues, and then review possible treatments and therapies. And I'm still going to be coming back to a case-based style. I just wanted to introduce the first case to you to get you started thinking about how to talk to patients about these topics. So talking about sexual health models, we start first with Masters and Johnson. I don't know if any of you are familiar with Masters and Johnson's model, but it was developed in the 50s. Masters was a physician, Johnson was a psychologist, and they were the first researchers to actually study sex in any way. And if you think about it, this was the 1950s. So how novel was it for them to even begin to wrap their heads around talking about and studying sex? They actually studied female orgasm. So their model is really based on a linear, and I'll show you a picture of it in a minute, 4-stage model, looking at excitement, plateau, orgasm, and resolution. They actually hooked women up to electrodes and induced in order to study the physiologic mechanism of female orgasm. Helen Singer Kaplan was a psychologist too. She added desire, and then it was a condensed model into a triphasic model with desire, arousal, and orgasm. So at least this opened it up beyond the pure bio mechanisms and was more of a psychobio mechanism. But Rosemary Bassan came along in the early 2000s and really revolutionized how we look at sexual health models. And when we talk about pearls and what I gleaned from my sexual health education, Rosemary Bassan's model is something that I use almost every time I talk to patients about desire. It's a circular model, really wrapped around women's responses to sexual cues, much less spontaneous and more responsive, and it emphasizes the role of intimacy and relationship satisfaction. So I'm going to show you a picture of each model. So this is Johnson, again, really looking at a very linear model, looking at excitement, plateau, orgasm, really looking at physiology of orgasm. And here's Kaplan. Kaplan comes along and adds desire, which is helpful. But here's Bassan's model. Now this is a little more complex than the next model I'm going to show you, which is my adaptation of Bassan's model that I actually use when I'm teaching patients about Bassan's model. But you'll notice that the model really kind of starts with emotional satisfaction, emotional intimacy, moving on to stimuli, arousal, and then desire. So there's two things about Bassan's model that I really want to point out that I think are so valuable in how we think about female sexual response. One, it's that arousal precedes desire. And if you look at the other models, this is really novel because women typically don't walk in the door thinking about having sex or sexual play or being intimate. They walk in the door at the end of the day, multiple things on their mind, multiple responsibilities. For my patients, they may have been at radiation earlier that day. They may be going through chemotherapy, or they may be finally done with treatment thinking about surgery or reconstructive surgery. So they're not thinking about sex. What we're is arousal precedes desire. So the difference is if a woman takes the time and her partner takes the time to help her become aroused, desire follows. So it's normal for women to not immediately feel desire until after arousal. The other thing I want to point out about Bassan's model is the role of emotional intimacy and relationship satisfaction. When women come in and start talking to me about decreased desire, one of the first questions, or the first question I ask is, are you in a relationship? Now, I do want to point out there is such a thing as self-sexual relationship, and that is important. And I do talk to women about that as well. But if a woman has given me the cue that they are in a partnered relationship, the first question I ask is, how is that relationship? And sometimes the answers I get, we know that that's where the problem is. I've had women tell me that they suspect their partner is not faithful or that their partner is abusive. And we really can't expect a woman to feel arousal or desire when the emotional and relationship intimacy and satisfaction is not there. So at that point, I'm looking to refer for more in-depth counseling and therapy. So here is Bassan's simplified model. This is the model that I started drawing out for patients when we'd be talking and they'd say to me, can I take that home with me? So what I did was I developed an educational booklet for my patients that outlines the most common things that we talk about in a sexual health consult. And this model is something that I give to patients because what patients have told me, can I take this home and share it with my partner? They want their partner to know that one, the relationship satisfaction is important, and two, they're normal because they need arousal prior to desire. Sometimes when I see folks, all we do is talk about this model, they look so relieved, a light goes off, you can tell that they feel like they completely understand. We've normalized what's going on with them, And sometimes that's all we end up doing is counseling them about the SANS model. It's important to ask the question. It's okay if you don't have the answers, but the worst thing we can do is not ask patients. So we can ask simply, are you having any sexual health concerns? Are you sexually active with a male or female partner or both? Again, never assume that your patient is in a partner relationship, and never assume that the partner is not necessarily same-sex or hetero. Are you having difficulty with arousal? Are you having pain with penetration? And I'm also careful with this because our patients in same-sex relationships and lesbian relationships frequently do use sexual aids and toys. You want to be sure not to say necessarily penis. You may want to frame it as penetration. And are you able to achieve orgasm? This obviously is the questions are going to be formed around the types of answers that patients give you. Implicit model, it's something that I use on a regular basis. So P stands for asking permission. May I ask you about your pain? If once they've told you there's a problem, ask, can we talk about this? Do you mind if I ask you? Now, when we think about the P implicit, yes, it's implying that we're asking the patient permission. But the other side of the P implicit, especially for patients that I'm taking care of, is normalize the problem for the patient, give the patient permission to talk about it. In other words, sometimes I say to my patients, you know, a lot of women on aromatase inhibitors experience vaginal dryness. Are you experiencing vaginal dryness? Or, you know, a lot can have pain with penetration after chemotherapy because of dryness. Are you experiencing pain with penetration? So the P, the permission, goes both ways. Asking the patient if they'd like to talk about it further, and giving the patient permission and normalizing the problem. Limited information. How long has this been going on? How often does it happen? Sometimes patients tell you this has been going on for 20 years. Well, then you know it's kind of out of the realm of what you may be able to introduce in a clinic visit, and you may need to refer that patient. Specific suggestions. You'd be surprised how many women don't know the difference between moisturizers and lubricants, and we're going to talk more about that in a few minutes. Intensive treatment referral. The patient that gives you cues that this has been going on a long time, maybe there's underlying depression, underlying abuse, and then you ask, would you like to talk to someone else? Even if this is all you do in 5 minutes, you've done something. So back to our case. Janet has revealed that she is in a same-sex relationship. Through our assessment, we've asked her some questions. She does not have pain with penetration. She began experiencing decreased desire about 6 months after her final menstrual period. So now we have a little more context to what her problems are, or what she's presenting with. So first, if I were talking to Janet, or when I talk to a patient like Janet, I normalize for her. I talk about the sexual health models. I review the SANS model and explain to her it's normal to not always feel desire first. Arousal often precedes desire. And I talk to her about rethinking sexual activity. Consider replacing spontaneity with anticipation. In other words, get ready for sexual activity, especially when we're talking about increasing arousal. All of the changes that happen to women with chemotherapy, oophorectomy, radiation, really do force women to rethink what their new normal is. Frequently, anticipation has to replace spontaneity. In other words, you plan for sexual activity. I'll talk more about things like dilators and lubricants and medications, but it sometimes takes getting ready, and that's just reframing what sexual activity and your relationship looks like. Also talks about the fact that arousal, there has to be more of a focus on arousal in order to get to desire. Sensate focus, I don't know how many of you have ever heard of or are familiar with sensate focus. I heard about it the whole time I was in my program at University of Michigan, and got through the whole program and didn't really know what sensate focus was until I did some more reading. So I want to provide a very abbreviated example for you of sensate focus. So sensate focus is a sex therapy technique that sex therapists will use with couples, where they basically course or penetration off the table and refocus intimacy and sensation. So when I'm taking care of a woman, for example, who is either experiencing decreased desire because of hormonal changes, medications, things that they're going through with their cancer treatment, or menopausal issues, pain with intercourse, things like this, I reframe this and I tell them, you know what, let's take sex off the table. Let's take penetration off the table, especially while you're doing some things to help your body heal. Let's focus on intimacy and not function. So phase 1, patients or couples are clothed or partially clothed, and they're just focusing on touching when clothed, and not on obvious erogenous zones. Intercourse, play, orgasm not permitted in this phase. Now, how long patients stay in this phase just depends on the couple. 2 weeks, 4 weeks. Phase 2, you introduce touch. You may introduce stimulations. Again, the focus is on intimacy. Phase 3, we finally start looking at some penetration, easier thrusting. The aim, again, is to continue to enjoy intimacy. So I also include this in the I give patients when I do a consult so that they actually have a tangible example. And this is adapted for either hetero or same-sex relationships. So Janet returns for follow-up. She and her partner have tried a sensate focus program. Decreased desire is still a problem. Her partner is understanding, but this is causing some distress for Janet. Now, I put this in here purposely to explain to you hyposexual desire disorder, or HSDD, as defined by DSM-4, has pretty strict criteria. And when two folks in a couple in a relationship both have decreased desire and neither is distressed, it's not a problem. The distress is what makes this HSDD. So her partner's understanding, but Janet doesn't like feeling decreased desire. Therefore, could this be a hyposexual desire as defined by DSM-4? So remember, sometimes folks mature, go through changes in life, and as a couple, they mutually agree upon what's a normal sexual repertoire. So decreased desire that neither member of the couple or in the relationship feel that it's a problem and does not have distress is not hyposexual desire disorder. In this case, this could be because Janet is experiencing distress. So now we can review some medical therapies and talk about what has been done and what's available. So Addyi is the first FDA-approved medication for HSDD. It is a 5-HT1A agonist, 5-HT2 antagonist, so you can tell if it's working off the serotonergic receptors. This was initially studied as antidepressant indication or for depression. Manipulating norepinephrine, dopamine, dosed at 100 milligrams at HS. Now they found that it didn't really help with depression, but they did have some improvement in desire. The study that was done for FDA approval was just under 500 women. It did have improvement in satisfying sexual events, reduced distress associated with low desire. Side effects were sleepiness, nausea, headache. I mentioned that this was in Marie Claire in 2014. I haven't seen a lot out there in the literature about Addyi, but there have been some follow-up studies. The problem with Addyi is it's contraindicated to drink any alcohol, or it's also called flibanserin. It's contraindicated to drink alcohol. I'll tell you about the alcohol challenge study. So what happened was they had 25 participants, 22 of which were males, because women would not admit to being moderate drinkers. And in order to take part in the alcohol challenge study, they had to admit to being moderate drinkers. So unfortunately, it was 23 men and 2 women who were in the alcohol challenge study. What they did was they gave them a 100 milligram tablet of flibanserin first thing in the morning. It is supposed to be given at night. Within 1 hour on an empty stomach, they had to consume either 2 shots of alcohol, 2 glasses of wine, or 2 8-ounce beers. And what happened? You can only imagine that quite a few of them had dizziness, near syncope, and syncope. So because of that, flibanserin earned REMS certification required, which is easy to do, something you can do online. The pharmacy also has to go through the certification. In our area, Walgreens is the number one, has been certified in order to dispense flibanserin. Should not be taken with the CYP3A4 inducers. Pretty common drug interaction. It takes about 8 weeks for full effect, working on neurotransmitters in the brain, not uncommon, and they did see an average of 4 satisfying sexual events a month. The problem I've had with fulvancerin is it's only indicated in premenopausal women, and most of my patients are postmenopausal, so I had a lot of difficulty getting this approved. I don't have a lot of experience with it. I think it's important to mention, though, that it is the only FDA-approved medication for decreased desire. Now the medications we'll be talking about are not FDA-approved and therefore off-label. I want to talk about testosterone. There's a lot in the literature about using testosterone systemically for decreased desire. There's been multiple studies. The studies are somewhat mixed, supporting the link between female desire and testosterone, and there is a poor correlation between actual androgen levels and sexual functioning in women. In other words, a lot of women with low testosterone have adequate sexual functioning. A lot of women with high testosterone don't have adequate sexual functioning. So the correlation that we see in men is not the same. We know that with the biochemistry, free testosterone decreases with aging, while the sex hormone binding globulin remains constant. Therefore, we know about 80% of testosterone is bound 19 to sex hormone binding globulin, 19% to albumin, which leaves very little free testosterone. For this reason, if you are going to prescribe testosterone off-label for a population for low desire, you really should use the free androgen index in order to calculate how much testosterone and to follow women's testosterone levels. Now, a normal postmenopausal testosterone range, and I am talking about postmenopausal women, primarily to 70 nanograms. This formula is, all you have to do is Google free androgen index. I'm sure multiple applications that you have on your phone for medical reference would have this in there in the app. But this is an easy calculation to find, and you're basically just plugging in total testosterone and sex hormone binding globulin. So in order to get your free androgen index, if you're going to prescribe testosterone, this is what you should be following. Prescribe testosterone, so I don't have any experience with it. I do know the literature. It is dosed in creams, patch, and oral. It's thought to decrease sex hormone binding globulin and therefore increase free testosterone. Most of the studies out there that look at exogenous testosterone for treatment of HSDD are looking at a transdermal patch. So this is the most common dose that I see in the literature. Again, I don't use it, but I am going to reference the most common dose in the literature is 300 micrograms per day. They did see increased satisfying sexual activity, increased desire, and decrease in sexually related distress. There are adverse events, which include hirsutism, acne, and deepened voice. I don't have any experience with it, so I can't really speak to the adverse events. The concerns still remain breast cancer and cardiovascular, although there's been no long-term data. There's been huge multi-center international trials looking at testosterone, and they really haven't been able to establish the risk with breast cancer and cardiovascular events. I want to mention that if someone is on oral estrogen therapy, even birth control pills, your patients that are taking oral contraceptives, this may increase sex hormone binding globulin, which reduces free testosterone, which may decrease desire. So I know that folks are familiar that sometimes when patients are on oral contraceptives or some type of hormonal contraception using estrogen, we can sometimes see decreased desire, and this is why. Lenotide is coming soon, I hope, and I'm extremely excited about this, and I do think that I'll be an early adopter of this medication when it's FDA approved. In June of 2018, they filed their letter with the new drug application with the FDA. It's based on a melanocortin peptide analog. If you think about what is in our sunless tanning products, melanocortins are neuropeptides that are associated with pigmentation, inflammation, and interestingly, sexual function. I think this drug really has promise. It was currently studied as an on-demand subcutaneous injection. Prior to these studies, it was looked at as an intranasal spray, but there were too many side effects, and actually hypertension was noted. So they did away with that type of administration and are now studying it as an on-demand subcutaneous injection, the same type of needle as an insulin needle. Phase 3 studies were just finished and presented at ISWISH. All endpoints were met. It was shown to improve sexual function. It takes 45 minutes for onset, so it is kind of, I hate to say the term women's Viagra, but in that sense, it is used as needed, and it has a limited half-life. So for nausea, flushing, and headache, there was no hypertension when it was used as an injection and not intranasal. I'm personally really excited about bremelanotide. I think I've been already talking to patients when we talk about what's available and what's coming, and believe it or not, patients are very open to this, especially because it's an on-demand. It is not something that you have to take every day. Addie or flibanserin, by the way, is something that you have to take every day. Inhibitors have been used, you'll see it in the literature, off-label as a mechanism to try and improve desire. They did see an improvement in arousal, lubrication, and orgasm, but no change in desire. So for women with actual HSDD, sildenafil did not show, which is Viagra, did not show any significant difference compared to placebo at any point at any dose. However, there are studies going on right now looking at local sildenafil for arousal, and female arousal disorder is a diagnosis that has remained without many treatments. So there is promise in this arena coming. Did not, however, have an effect on desire. But if you think about Bassan's model, I still think it would be amazing to have something to offer patients for arousal, because then if we're looking at Bassan, we know that we could perhaps get to improve desire. Wellbutrin has been used in divided doses. I have not used it. It is an antidepressant indicated really working off the dopamine and norepinephrine receptors. Studies showed an increase in function but not frequency. There was less orgasmic dysfunction than other SSRIs. I'm sure you're already familiar with the fact that many of our SSRIs can have sexual side effects. So it's a consideration that if your patient already has decreased desire and possibly has depression, Wellbutrin might be a good option. I have never used Wellbutrin solely for the purpose of increasing desire, but I know folks do use it off-label. So now I'm going to finish up with Janet. Janet actually did go into sex therapy and did report back to me that she was having relief through cognitive behavioral techniques to improve desire. She did not want to try Addie. I believe she's postmenopausal, so she couldn't get coverage for it. I did refer her to a sex therapist. Again, I want to emphasize the fact that if you're a clinician and all you do is talk to a patient about their problem and refer them, you have done something for them. So referral is an intervention. So moving on to case number 2. Connie is a 75-year-old female with a complaint of pain with penetration. She's already had a total abdominal hysterectomy and bilateral self-induced oophorectomy 20 years ago due to fibroid uterus. Talking to her further, she reveals she's in a monogamous new relationship with a male partner, not an uncommon thing that I will see in my population that is postmenopausal. She had not engaged in penetrative intercourse with a male partner in more than 10 years. Initial attempt resulted in significant pain. She was using a water-based lubricant and still experienced pain with intercourse. So, looking back at what we've been talking about, the first thing that you're going to want to do is assess and educate. You've got the information from the patient through your questions. Whenever I prescribe a medication for a patient for vaginal issues, I always do a vaginal inspection exam. I may not do a full pelvic or bimanual exam, certainly not necessarily a Pap test, but a vaginal inspection exam is necessary to evaluate any changes and also rule out any other vaginal pathology. Vaginal is now a bigger part of a classification called genitourinary syndrome of menopause. So ISWISH, the International Society for the Study of Women's Sexual Health, and the North American Menopause Society collectively worked on a new classification. It was felt that vaginal atrophy, first of all, women didn't want to say vaginal, and atrophy had negative connotation. Not only that, vaginal atrophy does not take into account things like urinary tract infection or some of the urinary tract issues that women will experience when vaginal atrophy is present. Therefore, genital urinary syndrome of menopause, or GSM, was adopted and is now part of the literature when talking about vaginal atrophy and dyspareunia, or any of the changes associated with menopause that happen physiologically to the vagina. So this includes both vaginal tissue changes, pH abnormalities, the pH becoming more basic, urinary symptoms such as leakage or frequent UTIs. When I'm talking to patients about this, I actually tell them what's happening to the vagina and talk to them about why. Many women don't realize that the dryness or irritation, itching, pain with intercourse that they're experiencing is because of menopause. They really don't know that it's part of the same sequelae due to lack of estrogen in the vagina. Women are very familiar with the fact that hot flashes are associated with menopause, but not vaginal changes. I also educate my particular population on what can happen when we induce menopause with chemotherapy or a surgical menopause with oophorectomy. Pelvic floor radiation can cause some of the same changes, as well as endocrine therapy, things like tamoxifen or the aromatase inhibitors, which many of my patients are on. It's important that patients understand what's going on and why. So I actually review with patients what's happening on a cellular level. So the vaginal maturation index becomes completely altered. The superficial cells, or the cells that are on the outside that produce lubrication, they stretch, are eventually replaced with the cells that are further down in the cellular makeup of vaginal tissue and vaginal epithelium with parabasal cells. These parabasal cells don't stretch, they don't produce lubrication, and they really give the appearance of what we see when we see atrophy in the vagina. We can see physical changes, which include the labia minora becoming less distinct, the clitoral hood can reduce, the tissue can at first be very erythematous, eventually become much more pale. The pH of the vagina changes. It becomes greater than 5, which is very basic, normal pH being 3.8 to 4.5. We can also see a repopulation of vaginal flora resulting in frequent urinary tract infections, and we see this a lot with the aromatase inhibitors. First things I'm going to do for Connie is review treatments. I'm going to review what's happening and why, and then treatments and therapies. Moisturizers and lubricants, according to the North American Menopause Society, are first line for the treatment of GSM. Second line is medications. I'm also going to talk about dilator therapy and vaginal stimulation. So when we're talking about moisturizers and lubricants, it always surprises me, it shouldn't, because so many women have relayed this to me, that women don't realize there's a difference between moisturizers and lubricants. They go to the drugstore, there's multiple products up and down the aisle, they don't know what to choose, they don't understand that one product is to be used as maintenance every 3 or 4 days, and another product is to be used at the time of intercourse for lubrication. So that's one of the first things I talk to women about. And remember, if this is all you do for a woman, you have done something, you've educated her. So the most common moisturizers that are in the drugstore are Replens and Luvena. These do not cure vaginal atrophy. They're used every 3 or 4 days. They attack epithelium and help restore a normal pH. Some of the products are better at pH neutralizing than others. They can help reduce pain, itching, and irritation. And you do still have to use a lubricant when sexually active or when engaging in penetration. So I do talk to women about lubricants, or excuse me, moisturizers. However, those two are not my favorite. My favorite is any that has hyaluronic acid. So hyaluronic acid was found to normalize vaginal pH, reduce itching, dryness, and dyspareunia, and improve the symptoms in some studies equivalent to local estrogen. Now, there are 2 products that I'm aware of that have hyaluronic acid that are intravaginal moisturizers. One is Halogen. I'm going to spell it for you. It's Hyaluogyn. The other is Revaree, Revaree. Now, Halogen is available online at halogen.com. It costs about $25 a month. You use it every 3 to 4 days. Revaree is actually a product that you get through a company called JDS Therapeutics. They are a company that produces supplements, specific supplements for menopausal symptoms. Reverie is where it does have hyaluronic acid and I believe oil in it as well. It is more of a suppository that is used every 3 to 4 days. Now, these are the only two products that I'm aware of that actually have hyaluronic acid. Unfortunately, I'm not aware of anything that is actually in the drugstore or over the counter. So it does require patients to get the information from you, perhaps go online and obtain it themselves. The cost of Reverie is, I believe, $35 for 1 month, $45 every month after that. And in order to find that, I would refer folks to JDS Therapeutics and going online looking at Reverie. So moving on to lubricants. Oh, by the way, I want to mention hyaluronic acid is an exception to moisturizers that cannot reverse atrophy. There has been studies comparing it to estrogen, and the fact is that it's improving collagen formation in the vagina. Hyaluronic acid is the same medication that's used in knee injections for arthritis. A lot of women are using it on their face as an anti-aging for the collagen formation. So that is the exception to moisturizers. If it's a moisturizer with hyaluronic acid, you can actually see some improvement in the actual vaginal maturation index and the pH. So then I talk to women about lubricants and make sure they understand that moisturizers are maintenance, lubricants is at the time of penetration. So I talk to women about what they may be using. Some women go in their bathroom and they grab Vaseline or mineral oil. One of the worst things you can use is a petroleum-based lubricant. It can be very irritating to the vagina, so I tell women don't do that. Some women go in their kitchen and they use olive oil. Coconut oil has been really hot for quite a while these days. There really isn't a reason why you can do that except for if they are using latex condoms, it can destroy latex products. I counsel women not to necessarily base lubricants. They are safe for all condoms and latex products, but they dry out quickly. And sometimes after a few minutes of friction, women notice they need to reapply. The water-based lubricant can get gummy and sticky. So for those reasons, I'm more of a silicone girl, and I recommend silicone-based lubricants for my patients. They're sometimes a little harder to find. They might be a little bit more expensive. I hear really good things from patients about KY liquid beads. The wet platinum works really, really well. I'm a big fan of Uber Lube. I don't have that one on here. It's UBER, like Uber, like as in the taxi service. But Uber Lube works really well as well. And it's pretty easy to find even if you go online. You can find these in drugstores. I just educate my patients to read labels. You can use a hybrid product that's both water-based and silicone. But the difference is the silicone lubricants, the molecules are larger, they don't penetrate through the skin, and you're literally going to be wiping off the lubricant after you're done. So you're not going to get that gummy stickiness that you're going to get with a water-based lubricant. So this discussion is an intervention. And believe it or not, there's been multiple patients that all we've done is had this discussion, they've gone home, they've gotten a good moisturizer, they've gotten a new lubricant, and that's all they needed. Janet switched to a silicone-based lubricant. She's been using something like Reverie 3 times a week for the past 12 weeks. She's still having pain when she attempts penetration. To medications. Now at this point, I would do a vaginal inspection exam and would talk about what's indicated for vaginal atrophy. Local estrogen is the only medication that's indicated for vaginal atrophy. Now remember, the FDA is pretty strict when they say things are indicated for certain disease processes. Estrogen is the only medication indicated for vaginal atrophy. It's available as a local cream, intravaginally, a tablet. We all know that's Vagifem, 10 micrograms, a vaginal ring. Be careful with this one and educate your patients that an S-string is a local action, works locally in the vaginal tissues, whereas Femring is systemic. And now there's a brand new product that is just now coming to market, FDA approved, probably available retail very soon, called Imvexxy, IMVEXXY, which is a vaginal soft gel ovule. It's available as 4 and 10 microgram soft gel tablet. There's no applicator. You simply insert it with your fingers about 2 inches into the vagina. It adheres to the vaginal wall and dissolves. It was recently FDA approved. The studies were excellent as far as studies of serum steroids. Efficacy was slightly different between the two. Obviously, 10 micrograms twice a week was more efficacious than 4. However, there still was clinically significant reduction in dyspareunia with 4 as well as 10. There is no indication to cycle for endometrial protection. So if someone is on a local estrogen, whichever way they're doing it, they do not need to cycle for endometrial protection if they have a uterus. I do want to mention local cream. It can be used intravaginally. Some of my patients, especially breast cancer, who we'll be talking about this in a little bit, are more comfortable using something just really truly locally. I tell women to squeeze about a half a teaspoon off onto their fingertips and massage it into their vaginal tissue, making sure they're covering their clitoris, urethra, vaginal opening with the estrogen cream 3 times a week. And we know that they do also get relief. Now, this isn't something that it's not marketed this way or indicated this way, but this is something I do with my patients who are really on whether or not they're comfortable using a local estrogen. There is a boxed warning for local estrogen for endometrial cancer and breast cancer. We have been trying to get rid of the boxed warning in general for local estrogen, and the FDA just shut us down again. We're trying to get rid of it because many of the side effects and warnings and precautions associated with systemic estrogen do not apply to local estrogen, such as blood clot, stroke. These things are not a risk when we're using it locally. However, the FDA will not get rid of the boxed warnings. Or ospemifene is a SERM that is indicated for dyspareunia. So you'll notice the semantics here of what things are indicated for has changed. Before 2003, when medications went through approval for treating vaginal atrophy and the symptoms of atrophy, the criteria was much more broad. In other words, vaginal acceptable criteria. After WHI, after 2003, the FDA decided that they wanted much more stringent criteria for medications to be approved for these types of conditions. Therefore, after 2003, every medication that gets approved for these types of disease processes and conditions is now approved for the most bothersome symptom of GSM, which is dyspareunia. And the FDA pretty much made that call. So now when you see medications approved, such as Osphena, we're going to talk about Interosa, our local DHEA, Imvexxy, which is a new estrogen, they are now indicated for dyspareunia. So it is the way the FDA approved these medications. We know that there are many other sequelae associated with vaginal atrophy, but this is the way that they are now approved. There was 2 12-week studies that showed improvement with daily use of 60 milligram Osphena or ospemifene. This is an oral pill that you're taking by mouth, stomach. They did see improvement in vaginal maturation index. Vaginal pH was reduced. And 1 year later, patients had sustained improvement with no causes of stroke, endometrial hyperplasia, or cancer. Now, it's a SERM. It's a lot like tamoxifen. It's really only a few molecules off. Can it reduce the risk of breast cancer the way tamoxifen can? It's very likely. In fact, many of the studies showed tissue, when they studied breast tissue, they found that it was at least breast neutral, if not breast antagonistic. However, it wasn't studied in a breast cancer population, therefore it's not indicated for patients with a history of breast cancer. And we also can't say that it reduces the risk of breast cancer. That was not the purpose of the study with Osphena. So it's only indicated for dyspareunia. Can I give it to a breast cancer survivor? Have I given it to a breast cancer survivor? Certainly. You just have to make sure you're disclosing that it's off-label and review all of the possible side effects and how the drug was studied. Because we do have the same risk profile as something like tamoxifen, with blood clot, stroke, and endometrial cancer. However, in Osphena, there was no cases of endometrial hyperplasia. The risk for VTE was much like estrogen. It is a SERM. Animal models stated had anti-estrogenic activity in several preclinical models for breast cancer. There was minimal effect on the endometrium with no incidence of endometrial cancer. So it is a nice option for patients. I've generally given it to folks who were done, obviously, with their endocrine therapy, such as aromatase inhibitor or tamoxifen. I could not in good conscience give this along with one of those medications because tamoxifen is another SERM, and I wouldn't feel comfortable with that. I would, however, feel comfortable if a patient came to me 5 years with treatment being 5 years ago and wanted to take a pill as opposed to something local with a history of breast cancer. I would feel comfortable. However, I would need to disclose that it is off-label. Now, one of my most favorite medications for treating dyspareunia is intravaginal DHEA or Interosa. I've actually been using this medication with patients for about 7 years. I broke my no compounding rule with DHEA because it was the only way that it was available. So I did used to compound intravaginal DHEA in this exact same dose that it is now FDA approved. Dr. Ferdinand Labrie, you'll see Labrie et al., his seminal article and phase 3 trials are available open label, so you can read about this medication and Labrie's work. I was comfortable compounding it. The studies were fabulous as far as efficacy, and there was no change in serum sex steroid above postmenopausal range. So in other words, estradiol levels, DHEA levels, and testosterone levels stayed very, very low with intravaginal DHEA. So I began using it several years ago. It became FDA approved about 1.5 years ago. It is Interosa. It is available at retail pharmacy. It is, again, not indicated for a breast cancer population because there has not been any studies with breast cancer patients. But we will talk about breast cancer in a little bit. It is, again, indicated for dyspareunia because it came out after 2003 and the FDA changed their criteria. So it is indicated for dyspareunia. As were discharged, less than 2%, abnormal pap test. So they studied about 500 women in the 52-week open-ended trial for the FDA guidance trials, and what they found were 11 cases of abnormal pap test. 1 was low-grade SIL, the rest were ascus, 5 were HPV positive. They really can't suggest there's a correlation. I always tell folks that if I looked at 500 patients in my pap test on them, how many cases of ascus would I have? So it really kind of reflects the general population. The patients entering the study, however, did have normal pap testing and then 1 year later had the abnormal pap tests. I don't know if it's because they were more sexually active, because they were more comfortable. I'm really not sure. Mechanism of action is unknown. It is metabolized the same as endogenous DHEA, so it converts to androgen and then estradiol. Off-label, and it is being studied right now for hyposexual desire disorder. It is off-label, noted to increase arousal, and they think it's because it increased nerve fiber growth and sensitivity in the vaginal tissues. Mention an important CMS update, May of 2018. CMS recognized that dyspareunia in postmenopausal women should not be considered sexual dysfunction, but rather a disease process or a chronic condition as a result of lowered estrogen. For it's no longer excluded from Medicare Part D coverage. This is a really big deal because our population who is suffering the most from dyspareunia related to GSM is our over 60, over 70 crowd. So this is really huge. This is extremely important. This is no longer going to be excluded. Local testosterone, now we're not talking about systemic like we were talking about earlier for patients for decreased desire. There is quite a bit of literature looking at local testosterone for GSM and dyspareunia. Atrophy. There was a study where there were 21 breast cancer patients on aromatase inhibitors using local testosterone. Their serum estradiol levels remained below 5 picogram, and there was improvement on atrophy symptoms. There is thought now in the literature we have androgen receptors in our vagina. So that's possibly why we're getting a good effect from local testosterone. I want to mention the less than 5 picogram DHEA in case you're wondering. When they looked at that, women were noted to have less than 4 picograms per ml. And in estrase cream, or is it Premarin cream, women were noted to have less than 9 picograms per ml, if that gives you any kind of comparison. Now keep in mind, these are measurements that cannot be found without mass spectrometry. It's reserved generally for patients in study when we really want to look at serum sex steroids. So we're talking about extremely low numbers of steroids. I want to mention vaginal CO2 laser therapy. I have had a couple of patients who have had the Mona Lisa, if you've heard of that. Basically non-surgical laser that's used to induce the production of new collagen and elastin fibers. Vaginal laser has been associated in decrease in symptoms of GSM, histopathology, and restoration of vaginal flora. The body of evidence is low, and studies are sponsored by manufacturers. Therefore, we need more study. The jury's out still as far as I'm concerned. The procedure is FDA approved, but it is not FDA approved to the point where it's actually covered by insurance. So women are paying out of pocket. It takes usually at least 3 treatments, usually a couple $1,000s. Again, I've had a couple patients who have done this and done well. It's something I tell patients that it's out there, but I really can't say I'm a proponent or that I'm against it because I'm kind of waiting for more trials. More treatments with patients. We've outlined multiple treatments for dyspareunia. Consider other comorbidities. Think about the adverse events of each treatment, the most common being vaginal discharge, and consider any other circumstances such as decreased arousal or difficulty with orgasm. For example, if my patients tell me this, then I make sure I share with them that off-label Interosa did have increased arousal. Yes, pemifene, 60 milligrams daily. She's still experiencing pain and anticipatory fear of pain when attempting penetrative intercourse. What can you offer at this time? So I frequently see women who, because they've attempted intercourse so many times with so much discomfort, they're now clenching and having difficulty because they can't imagine how much it's going to hurt if their partner attempts penetration. I call this anticipatory fear of pain or anticipatory pain. And I talk to women about this. This is when I really talk about dilator therapy. Now, to be honest, I would have talked about dilator therapy at the same time that I talked about medications with this patient, but I wanted to systematically present the medication options to you. So dilator therapy, if a patient tells you it's been a year, it's been 10 years, it's been 5 years, and they have not had penetration, you really do want to talk to them about vaginal dilator therapy. Dilators can be bought online. I can't find them at a store by me or at a medical supply store by me, but they are available online. They're considered a medical device, so I tell patients some resources or vaginal dilators. I tell patients to get a set of 4 or 5, depending on how many they want. I advise them to start using the dilators about 2 weeks after some type of therapy. So in other words, 2 weeks after Asphena or Aspemifene, 2 weeks after a hyaluronic acid moisturizer, 2 weeks after Interosa. The point is, start healing the vaginal tissues and then introduce the dilators. There are various sizes, and I explain to patients to use a lubricant on the dilator. They can either use them alone or with a partner as part of their sexual play. Sometimes it's easier for women if they're using them alone because, again, the pressure is off and they're just seeing how each dilator size fits. I tell a woman to start with the smallest and gradually increase in size. And by the time they get to the largest dilator, they hopefully will have comfort, and then they will know that a penis is going to feel about the same and not necessarily have anticipatory pain. Stretching does work. It's in the literature. We do recommend vaginal stretching along with medications. And again, it's in the North American Menopause Society guidelines as well for vaginal atrophy. Something I also talk to women, and I talk to them, I use either the term masturbation or stimulation depending on the patient, on cues that she has given me on how comfortable the conversation is going. If I feel that she really wants to keep things more clinical, I use the term stimulation. Sometimes I ask, have you ever masturbated? If someone's very uncomfortable with this, I want to frame this for them that it's a clinical intervention, something that we can do to increase blood flow and to improve pain with intercourse. Or with penetration. You do have to be culturally sensitive and ask, is this something that they're comfortable talking about or even something they're comfortable doing? I tell them, I give them permission, do it alone or with a partner. And I educate women that there actually was a wonderful study by Schroeder and colleagues, and I even include this information in the booklet I give patients, so that they understand it really is a clinical intervention. Schroeder and colleagues used a clitoral pump to increase blood flow and engorgement directly to the clitoris. Now, patients don't have to use an Eros device. They're very expensive. They're about $300, but they could use a simple vibrator, something that's relatively inexpensive. The point is direct clitoral stimulation and inducing orgasm 3 or 4 times a week through either self-stimulation or some type of device was shown to show significant improvements in desire, arousal, lubrication, orgasm, satisfaction, and pain. So I explained to women, this is a medical intervention. I'm giving you permission. Sometimes I've even written it on a prescription. Self-stimulation 3 times a week for 12 weeks. And that's pretty much how this study was. So it is very important to talk to women about stimulation and it for them as well. I also talked to women about pelvic floor rehab. I love my pelvic floor therapists. I'm fortunate enough to be in a Metro Detroit area where I have access to a lot of pelvic floor therapists. I explained to women that these are physical therapists who go through specific training for pelvic floor rehab. My patients who've had radiation, by the way, the Schroeder study, those patients had cervical cancer and had pelvic floor radiation. So when I tell my cancer patients or my pelvic floor patients this, they're even more intrigued. So when I have a patient that's had pelvic floor radiation for colorectal cancer, vaginal cancer, ovarian cancer, I refer frequently to pelvic floor physical therapists. I think they do an amazing job. They do great work. This population still may very well benefit using something for vaginal atrophy and dyspareunia, but I do think that if there is a lot of scar tissue from radiation, they would really benefit from this type of provider. So my lab used a dilator and actually tolerate intercourse, just to give you an update. So case number 3, Bobby presents with pain with penetration and frequent urinary tract infections, defined by more than 4 a year, which is pretty standard. Urogynecological evaluation confirmed genital urinary syndrome of menopause, so she had physical symptoms. She was offered vaginal estrogen, but was afraid to use due to fear, so she presents to me. Further assessment revealed that she had invasive breast cancer at the age of 42. She was treated with a mastectomy and radiation therapy. She also had strong family history of breast and ovarian cancer and opted to have a bilateral oophorectomy. She's now on an aromatase inhibitor. This is like a triple threat. So this poor young woman at 45 has had multiple reasons to have pain with penetration. She's by definition menopausal. She's had an oophorectomy. Now she's on an aromatase inhibitor, which is notorious for depleting estrogen to the point of causing severe vaginal atrophy. First-line therapies. Now, this is our patient with a history of breast cancer. Of course, we do have to review lubricants and moisturizers. We talked about dilators and stimulation. I disclosed to this patient, as I do most of my patients with a history of, because most of my patients have a history of cancer, and to all of them, breast cancer, that there are no FDA-approved medications that can be used, that are used, are approved, excuse me. There are no FDA-approved medications for use with history of breast cancer to treat dyspareunia, that everything we're going to be talking about is off-label. I make sure women understand. I talk to them about everything that I've talked to you about today, but they have to know that because they have a history of breast cancer, they're all off-label. I also think outside the box with these patients. We talk about the vaginal CO2 laser, pelvic floor physical therapy. Estrogen in breast cancer, it's considered off-label for a breast cancer population. About it. And I also share with patients, and I've actually given patients copies of the ACOG opinion paper. I've had patients tell me that they've gone home and looked it up after I've talked to them about it. The ACOG opinion paper was March of 2016 and basically looked at all of the evidence that we do have of patients with a history of vaginal atrophy and breast cancer and found that overall it was safe for women with a history of breast cancer to use local estrogen. We're talking about local estrogen only. So there are no good randomized controlled trial head-to-head. These folks had breast cancer and used local estrogen. These folks did not. We don't have studies like that, but we do have a lot of different studies looking at women using different modalities when they have a history of breast cancer to treat GSM or vaginal atrophy. And overall, looking at these studies, ACOG came to the opinion that it was safe for women with a history of breast cancer to use local estrogen. Non-hormonal therapies remain first line, however, according to guidelines. There's no evidence to support a reoccurrence of breast cancer in women using local estrogen. However, there's no evidence to support safety. A study that showed reoccurrence, but we don't have a study that shows there isn't a risk of reoccurrence. So I review with patients what I know and what I don't know, what the literature tells us and what the literature doesn't tell us. And I review reoccurrence fears. In other words, if I put someone on local estrogen with a history of estrogen-positive breast cancer, I point blank look at them and say, if you have a reoccurrence in a year, are you going to think that it's because you used Imvexxy twice a week intravaginally? I absolutely do not think that's why you had a reoccurrence. Breast cancer can reoccur, but a woman has to be comfortable and has to think about that for themselves. HEA in breast cancer. This was one of the reasons why I started using this. I was an early adopter about 7 years ago. Again, still, even though it's FDA approved, off-label still in a breast cancer population. It wasn't studied in a breast cancer population. Estrogen is a metabolite. I talked to you about the metabolism. It starts off as DHEA, metabolizes to androgen, and then and then estradiol. It's a metabolite, therefore it's a precaution, and that's an FDA requirement. It's not a boxed warning, however. So I review again with the patient what is known, what is not known. I may even tell her about the serum sex steroid studies and how much estradiol they were actually able to detect in the blood. I talk about reoccurrence fears with patients. If you go on Interosa, are you going to feel like you're going to give yourself back breast cancer? I do not, but you need to feel comfortable. Not indicated in a breast cancer population, wasn't studied in a breast cancer population. I tell patients in animal models we saw anti-estrogenic activity in the breast, similar to anti-estrogen activity such as tamoxifen and relaxafene. It is not tamoxifen or relaxafene, but it's very similar. And shared decision making. All of these discussions with your patients are about shared decision making. It's about introducing what we have available, what we know about what we have, include all the options, all the risks, including risks of fears about reoccurrence. Talk about the reality that there are no treatments for vaginal atrophy or dyspareunia that are FDA approved, but that doesn't mean, with a history of breast cancer, that doesn't mean we don't talk about it. This does require time and a very frank risk-benefit discussion with patients. Share with you that this year, the Journal of Clinical Oncology released their interventions to address sexual problems for folks with cancer. It was an adaptation of the Cancer Care Ontario guidelines. This is very exciting. One, because I work in the cancer world, my colleagues are usually not thinking about patients' sexual health the way I am. They send them to me, which is great. But I love the fact that the oncology world is talking about sex and addressing sexual health issues with patients. The other reason why this was exciting is there's this actual quote in the actual ASCO guidelines: women with a current or history of breast cancer who are on aromatase inhibitors and have not responded to previous treatment, clinicians may offer intravaginal DHEA. So this was extremely cool for me to see, because I thought, imagine that. I've been doing this for 7 years, and ASCO now thinks it's a good idea. So I was pretty excited about that. Again, this isn't a formal guideline. This is based on advice for clinicians, but I think it's extremely encouraging that this was included in the sexual health guidelines. I was going to give you some resources. North American Menopause Society, multiple resources for menopause and sexual health. There's a MenoPro app. The website is extremely valuable. They have a clinician side and a professional side. The 2017 hormone therapy position statement is something you can access just by going on the website. All of our position statements are actually available. Lots of great resources on the NAMS website. WH has a Well Woman mobile app as well. That's a good resource. This is an actual CME offering where the experts are talking about Guide to Menopause Management and the WHI. So if any of you have any interest in that. I love this website. This is actually a friend of mine, Dr. Barb Dupree. This is her website, Middlesex MD. Patients can go on this website, and if you notice way up in the corner, there's a little shopping. So she not only does she blog with patients, she answers questions. She has products that are learning products, such as books, videos, things for patients. She also has a store that has dilators, vibrators, moisturizers, lubricants, lots of good resources. I love this website.